So today we have a invited speaker, Dr. Radhesh, who is the radiologist here. To give you a brief introduction, he started his career in Bangalore at Bangalore Jubilee Camden Diagnostic Center, and then he started his own diagnostic company, what is called as Clumax Diagnostics. I'm sure all of you are in Bangalore are very familiar with that. It merged with Medall, and he was instrumental in expanding it to 150 centers. Then after his contract is over, he again started his own advanced diagnostics center called as Celera Diagnostics in Jayanagar. I have invited him to talk on CT and MR in clinical neurology because I know him well. He's not only a good human being, he's a good teacher who has delivered several innovative talks. And today I'm glad he has accepted my invitation to give this talk to you. So over to Dr. Radhesh. You can start now.
Yeah. So friends, a very good evening. And first of all, I would like to thank my teacher, mentor, whatever, philosopher, and I'm not wrong in calling him my godfather. Sir, thank you very much. And I owe everything to you today because I still remember the way you taught me to go about not just radiology, but also how to address people. You always said, talk to the audience and know your audience before you start. And today, I think I would have delivered more than 500 talks, but every time I ask, who are my audience? So I think, friends, that is very, very important. And Sir has been instrumental in developing so many wonderful doctors across medicine and neurology. So what I'll be doing today is, there are two parts to my talk. First is a talk on CT. I'll just introduce you say to axial and spiral CTs. These are all just hardly 30 seconds. You have to know what an axial CT is, what a spiral is, and then we look at the conditions. We look at trauma, we look at infections, and we look at a few tumors. So this will be the first part of my talk, and the second part of my talk is going to be on MR. In CT scan, we call this CT, not CAT, meaning it's computerized tomography. It is no more computerized axial tomography because we can also take coronal sections, we can do reconstructions in different planes. So when it comes to the spiral CT, it is a multi-slice CT or a multi-detector CT. There is always a confusion as to whether it is an MSCT or an MDCT. Both mean the same, meaning we are taking more than one slice. We are taking 2, we are taking 4, and today we take up to 256 slices. So that is a multi-slice CT where you get an entire volume acquisition, and once you have the volume data, you can reconstruct in whatever plane you want to, and you can do very good 3D reconstructions. Now let us look at the advantages of CT. So why CT? CT today is very, very fast. We were taking one slice in 9 seconds, okay, 20 years back. But today we do the whole body in 10 seconds. That is where we are today in terms of CT. It is an excellent modality as far as trauma is concerned. And in evaluating hyperacute bleed, subarachnoid bleed, and calcifications, which sometimes can be missed on MR. And it is cost effective as compared to MR. What are the disadvantages of CT? So you should know this. Radiation is a big disadvantage because with the multi-slice CT coming in, though the collimation is very narrow, we are still irradiating the patient. So we have to be extremely careful when asking for the CT. Multiplanar imaging is not possible. You can reconstruct in multiplanar planes, but you cannot acquire the data in multiplanar planes. First trimester pregnancy is a contraindication. But beyond first trimester, when organogenesis is over, we weigh the benefits to the risks. Okay, if the patient is going to be benefited by a CT, we still go ahead with the CT, but we try to avoid iodinated contrast as it may cross the placenta. Now, reaction to iodinated contrast is one more contraindication or a disadvantage. If the patient is sensitive to iodinated contrast, we cannot inject iodinated contrast. In CT, we use iodinated contrast. And when it comes to MR, I'll tell you what contrast we use. And one more thing is, if the patient is renal compromised, say the patient's creatinine is 1.4, borderline, we avoid giving iodinated contrast because most of these contrasts are nephrotoxic. Even if it is isoosmolar with plasma, still it is nephrotoxic. So we try to avoid giving iodinated contrast in such patients. Let's look at the normal anatomy for 2 to 3 minutes. Now, this is the posterior fossa and supratentorial region is here. So posterior fossa, we see the cerebellar hemispheres, and you can see these black streaks here. These are beam hardening artifacts. So MR will not throw these artifacts. That is the beauty of MR, where you can see, visualize not only the posterior fossa, but also the brain stem very well. The midline structure here is the fourth ventricle. And then when we come to the supratentorial region, we have temporal lobes. Then we have frontal lobes, which are anterior to the sylvian fissures here. These are the frontal horns of the lateral ventricles. These are the occipital horns. And the black structures you see here, this is the anterior limb of internal capsule. This is the genu of internal capsule. And this is the posterior limb of the internal capsule. As we go superior, we start seeing bodies of the lateral ventricles, and then we see the frontal lobes anteriorly. And sometimes on CT, you can still see the central sulcus very well. So the moment you see central sulcus, you know that the structure anterior to that is the frontal lobe and posterior to it is the parietal lobe. So initially what was happening is we were not able to see the central sulcus very well on MR, on CT. So we could not differentiate exactly which is the frontal lobe, which is the parietal lobe. But today, with the resolution of CT also being so good, you can clearly see the central sulcus well, and then clearly say that the lesions in the frontal lobe or the lesions in the parietal lobe, which can be well differentiated. Let's look at a few conditions here. Now, arachnoid cyst. Okay, we'll also see these on MR and see how we can differentiate this from epidermoid cyst. This hypodense area is CSF density. Now, if you look at CT, there are three terminologies what you need to know: hypodense, isodense, hyperdense. Hypodense meaning it is like CSF. Isodense is like brain parenchyma. Hyperdense, which is white, meaning it can be calcification, it can be fresh bleed, or it can be something like bone. So this is an arachnoid cyst in the right temporal region. Do not say right temporal lobe. The reason is all these arachnoid cysts are extraaxial lesions. They are not intraaxial. So the moment it is extraaxial, it is better to use the word in the temporal region. One illustration here of a colloid cyst. These patients can come to you with symptoms of hydrocephalus because this is an anterior third ventricular lesion and it can obstruct the foramen of Monro. Once the foramen of Monro is obstructed, then you see dilatation of the frontal horns and the bodies of lateral ventricles. And these colloid cysts on CT appear hyperdense. They appear like blood. Sometimes it becomes difficult for us to differentiate between blood, colloid cyst, and a basilar tip aneurysm. So we should be careful. And MR is the investigation of choice in all these. I'm just introducing you to CT and telling you how the lesions appear on CT without going into too much of details. Let's look at a few traumatic cases, how they appear. This is an extradural hematoma, and extradural hematomas are biconvex hematomas. If you look at the inner margin, it is convex towards the brain parenchyma, and the outer margin is convex and along the cortical margins. So it's a biconvex hematoma, or we also just call it as something like the shape of an idli. If you know idli, it's a biconvex edible thing. So extradural hematomas also appear biconvex. Now, how do you differentiate this from subdural hematomas? Subdural hematomas are concavo-convex, concave towards the brain parenchyma, convex towards the calvaria. So they are semilunar shaped hematomas, and all acute hematomas are hyperdense. Okay, hyperdense meaning they are brighter than the brain parenchyma. They may not be as bright as bone, they may not be as bright as calcium, but definitely they are brighter than the normal brain parenchyma. So we should be seeing not just the hematoma here, but we will also have to see if there are other lesions. Okay, is there a fracture? Is there no fracture? Is there pneumocephalus? So how does pneumocephalus look? Pneumocephalus looks like pockets of air within it. Air and CSF are two things which appear dark on CT. That is hypodense on CT. Hematomas, let it be extradural, let it be subdural, or even subarachnoid. They appear hyperdense on CT. And look at this subarachnoid bleed. Fresh blood always appears hyperdense. So let's go back now. So this is an acute subdural hematoma. Now, after 7 days, what happens? The density of the hematoma slowly becomes less and less, and as it approaches chronicity, it becomes hypodense. So you can see this is hypodense. It may not be as dark as CSF, but it is definitely hypodense. And you also see a small fluid level here, and this part is the fresh blood. So this is actually an acute and chronic hematoma because fresh blood is more dense, so it gravitates down and it settles down, and rest of the subdural hematoma can be seen anterior to it. Now, what is important for us also to see whether the sulcal areas here, the sulci are effaced. Is there a compression on the lateral ventricle, which is there in this case? Is there a compression on the brainstem? Yes, it is there in this patient. So it's important for us to communicate to the surgeon that yes, this is a subdural hematoma, acute and chronic, with a midline shift of say 1 centimeter, 1.5, so they can go ahead and do a burr hole. This is a case of bilateral subdural hematoma. You can see this. There is a concavo-convex hypodensity. Again, the concavo-convex hypodensity is seen here on the right. And these two are compressing the underlying cerebral parenchyma, and there is no midline shift because they are balancing each other. If there was only unilateral subdural hematoma, as we saw in the previous case, we would have seen a midline shift. But in this case, there is no midline shift. Now, two important pitfalls what we see on CT, especially if there is a bleed along the tentorial leaflet, we may miss out on CT because the tent looks bright or hyperdense, and the bleed also looks hyperdense. So if there is a subdural along the tent, we will miss out. Second thing is, just look at this image. We will say, if we are not aware, we will call this normal. This is the gray matter, this is the white matter, so everything is fine. So CT becomes difficult when the subdural hematoma is isodense to brain parenchyma. So if the bleed is isodense, we may miss a subdural hematoma on CT, but we will never ever miss a subdural hematoma on MR. The reason is we can see different phases of blood on MR, which I'll be showing you. This is again a bilateral, subdural, and then subarachnoid bleed. Acute subarachnoid bleed. You can see this. There is an acute subarachnoid bleed in the right sylvian fissure and an acute subarachnoid bleed within the interpeduncular cistern. So acute bleed will appear hyperdense. So once we see this, if the patient has an aneurysm, then I think we need to go ahead with an angiogram. And the gold standard for angio today is still DSA. Though we have a 128 slice CT, we have state-of-the-art MRs, still angio is the gold standard to pick up aneurysms. So it is not CT, it is not MR. Though we may see the aneurysm, to define the neck of the aneurysm and also to define the exact size of the aneurysm, DSA is the gold standard. Intracerebral hematomas. So this is an intracerebral hematoma, and you can also see the layering here, and it is bright or hyperdense. So we know this is an acute intracerebral hematoma. And there is some bleed also here within the sylvian fissure. So there is associated subarachnoid bleed. And there is mass effect. You can see compression of the third ventricle. There is significant surrounding edema and effacement of the adjacent sulci. This is one area which is very tricky on CT. So until we have seen a lot of cases, we may miss this subtle finding. If you look at carefully, you see a fluid level within the body of left lateral ventricle. This is the bleed within the ventricle, and you see a level here. This is blood, this is CSF, and you see a fluid level within the left ventricle, body of the left lateral ventricle. So this is an intraventricular bleed. So we have looked at extradural, we have looked at subdural, we have looked at acute, chronic, subarachnoid we have looked at, and this is intraventricular bleed. Then continuing with trauma, hemorrhagic contusions. Look at the way it is distributed. Usually these are cortical, subcortical, and the hypodensities is the edema, and hyperdensity, what we see here, is blood. So this is an ill-defined hypodense area which is interspersed with hyperdensities. That is how we define a hemorrhagic contusion. Similarly here, you see a hyperdensity here, you see a hypodensity anteriorly. So this is again the case of hemorrhagic contusion with encephalomalacic changes. Now, why do we say encephalomalacic changes? The moment we say encephalomalacic changes, that means we are talking of chronicity. If it is chronicity, then what do we see? We see adjacent areas which are prominent because of the gliosis. You see dilatation of frontal horn of left lateral ventricle. See the dilatation here. So we know that this is a chronic case of hemorrhagic contusion because the patient had a history of trauma. It's extremely important for us to take the history and evaluate, and this is encephalomalacia with dilatation. This is again a case of hemorrhagic contusion within the right temporal lobe. Conthrecu injuries. So Conthrecu injuries is we see the extradural or subdural on one side, and then a contusion or an extradural or a subdural on the opposite side. Okay, this is a Conthrecu injury where hemorrhagic contusion is seen within the right frontal lobe and extradural hematoma is seen within the left temporooccipital lobes. And these are again hemorrhagic contusions. I'll show that to you again on MR. These are hemorrhagic contusions within the frontal lobes, and these are MR images where you can see it so well. Last slide on trauma. This is a patient with CSF rhinorrhea. I think it's extremely important for us to diagnose this very early because of the risk of meningitis. And the best investigation of choice as of today is CT cysternography, not MR. Okay, CT cysternography is the investigation of choice for CSF rhinorrhea, where you see the CSF leaking into the nasal cavity. This is a large defect within the cribriform plate, and the CSF is leaking through the cribriform plate defect into the nasal cavity. Now, let's look at infarcts. So when we look at infarcts, again, the gold standard for imaging of infarcts is MR. CT is done just to rule out bleed. If there is no bleed, then we know it is infarct. But to pick up infarct, MR is the investigation of choice. So now this is an acute infarct. Look at this. It can either be wedge-shaped or something like a quadrilateral shaped hypodensity. And the MCA is bright. This is called as hyperdense MCA sign. If it is hyperdense MCA sign, we know we are dealing with an acute infarct. So these are the patients who will be taken up for thrombolysis. Again, I need not tell you about the golden hour. It's extremely important that stroke patients reach an investigation or a diagnostic center or a hospital within 1 hour. And the treatment should again start within the hour. That is the golden hour. So we do the stroke protocol in 10 minutes and then hand over the case to the neurophysician who will treat these patients. Post-infarct porencephaly, you can see this is a chronic one, hypodensity, and there is dilatation of the left frontal horn, post-infarct porencephaly. Intracerebral hematomas can be hypertensive or non-hypertensive bleeds, and this is a patient with left basal ganglionic bleed. This is also left basal ganglionic bleed, and you see right cerebellar bleed, and this is subarachnoid bleed. So all the acute hematomas are hyperdense. Here, it's very difficult to age the hematoma. I'll show it to you in MR where you can pick up acute, early subacute, late subacute, and chronic hematomas just by looking at their signal intensities. So this is again one more illustration of acute intracerebral hematoma with ventricular spillage. You can see the blood going into the ventricular system. Dural sinus thrombosis, again, MR is the investigation of choice. And this patient, post-contrast, shows a filling defect within the superior sagittal sinus called the empty delta sign. And you see a hemorrhagic infarct in this patient, which is a venous infarct. And these venous infarcts are not as well defined as that of arterial infarcts. So infections, now it is actually quite rare. There's an intracerebral abscess in the left occipital lobe with surrounding edema. And how do you say this is an abscess? There is central hypodensity and the periphery shows uniform thickness ring enhancement. Uniform thickness ring enhancement. That is an abscess. If the thickness is significant of the capsule and you still see a central hypodensity, this is a tuberculoma. Okay, thick peripheral enhancement with surrounding edema. Small lesions, you see this multiple small lesions, few of which are calcified, and this is classical for a cysticercosis. So where the scolex gets calcified, and when the cyst starts degenerating, you will start seeing surrounding edema. That is a degenerating cysticercal larva. So this is in fact a child with meningitis. You can see basal enhancement. There is dilatation of the fourth ventricle, dilatation of the lateral ventricles, classical for a communicating hydrocephalus. If there was an aqueductal stenosis, you would have had dilatation of the third ventricle and the lateral ventricles, which becomes an obstructive hydrocephalus, but this is a communicating hydrocephalus. Just a few more slides on CT. This is a classical odontoid fracture. This is, you can see the base of the odontoid being fractured, but there's no atlantoaxial dislocation. Jefferson's fracture, where you see the posterior arch of atlas being fractured and also the anterior arch. So for fractures, CT, CT, and CT, no MR. Again, this is a C2 fracture. So the last few slides here. This is a large acoustic neurinoma. Patient came with hearing loss, but see the images are so bad. You see too many artifacts on CT. Large pituitary macroadenoma. You see the macroadenoma, patient with acromegaly. This is a large meningioma, what you see in the occipital region, and there is an arachnoid cap surrounding the meningioma. This is very classical. You start seeing arachnoid caps wherever there are meningiomas, and also dural tail. This is an oligodendroglioma. Oligodendrogliomas, one thing what we need to remember is they have calcifications. Majority of oligodendrogliomas. Gliomas have variable wall thickness enhancements. You can see the variable wall thickness enhancement. So variable wall thickness enhancement is a feature of glioma. And then homogeneous enhancement is a feature of lymphoma, and lymphomas are usually periventricular in location. But the abscess you saw showed a uniform thickness ring enhancement. Multiple lesions with variable wall thickness enhancement and nodular enhancements with surrounding vasogenic edema, very classical for metastasis. So I would like to just conclude the first part of my talk here. Quickly, I'll go into MR. So in MR, I'll first talk about the normal anatomy for say 1.5 minutes, and then we'll start looking at the lesions. So for neuro imaging, okay, MR is the investigation of choice. In fact, I told you we may use CT for calcification, and one place where we use contrast for CT scans is when we look at meningitis, when we look at tumors, when we look at infections. So these are the areas where we use contrast. For rest of the things like trauma and all, you don't need to use CT contrast. Now, when it comes to MR, MR has multiple sequences. We call it T1, T2, flare, gradients. Okay, so I'll just tell you how to differentiate these initially. So these are T1 weighted sequences. The second row is T2 weighted sequence. So how do we differentiate T1 from T2? T1, if you look at CSF, CSF is dark in color or hypo-intense, and the surrounding brain parenchyma appears grayish on T1 weighted sequence. On T2 weighted sequence, CSF becomes white or hyper-intense, and the white matter appears dark, gray matter appears white. So the signal intensity of gray matter is slightly hyper-intense to that of white matter, and white matter appears hypo-intense or dark. And these are coronal sections. This is a sagittal section. And anatomy-wise, I think now you know already, the cerebellar hemispheres in the posterior fossa, fourth ventricle. Then you have the pons, heart-shaped structure, which is the midbrain. Then you have the supratentorial temporal lobes, sylvian fissures, medial portion of that being the insular cortex. Anteriorly, you have the frontal lobe. Posteriorly, you have the occipital lobes. And superiorly, you have the parietal lobes. You can see the central sulcus so well on the MR. You can see the central sulcus on the left, central sulcus on the right. So whatever part of the brain is anterior to it is the frontal lobe, and posterior to it is the parietal lobe. Because this becomes very important in differentiating, like based on the symptoms of the patient, when you examine, you will know whether it is a motor cortex or a sensory cortex lesion. So in MR, the contrast what we use is not iodinated contrast. It is a paramagnetic substance. So what does gadolinium or MR contrast do? It reduces the T1 of the flowing blood. So once it reduces the T1, T1 is the value of the flowing blood, it appears white. So that is what you call as enhancement on the MR. Now, what are the other structures which can appear white on MR? One is fat. Second, it is extracellular methemoglobin. I'll show you those images. So one is fat, second is extracellular methemoglobin, which appear hyper intense on T1 weighted images. Now, to differentiate blood from fat, you need to do a fat saturated sequence, meaning you suppress the fat. If it gets suppressed, it is fat. If it is not suppressed, it is blood. Now, let's look at MR in stroke, because this is, I think, the most important thing what we do on MR, especially in acute cases. Now, the important thing here is time saved is brain saved, time lost is brain lost. Okay, people, if they have a chest pain, they just run to the cardiologist. But I have seen in neurology, patients come with stroke, and when we ask them, they say it is 3 days old, 4 days old. I think we cannot wait. The golden hour is the first hour, whether it is a hospital or a diagnostic center. I think we need to address imaging of these stroke patients, and it cannot exceed 10 minutes. Now, what do we do in 10 minutes? We do a T1, we do a T2, we do a diffusion weighted, which is very, very important. And ideally, we have to do a perfusion weighted sequence after injecting gadolinium. I'll show you that. And we also need to do an MR angiography. All these within 10 minutes. Patient in, patient out, not more than 15 minutes. I think it is very important. So we take away 15 minutes of the golden hour, and what remains for the patient coming into the center, going out of the center, is only 45 minutes. So it's important the treatment starts within 1 hour. Now, for easy understanding, I've just divided this into 4 P's. One is parenchyma, which is the brain parenchyma. Second is perfusion. Third is pipes, which are the blood vessels. And fourth one is penumbra. Penumbra is one which we are going to save when we treat these patients. Now, parenchyma, we do a diffusion weighted sequence. Look at this. This is a diffusion weighted sequence. So what we do in diffusion weighted sequence is that it's a machine generated software where we add diffusion moments, meaning we try to restrict the flow of hydrogen protons. As such, in acute infarcts, there will be cytotoxic edema, and these cytotoxic edema restrict or limit the movement of hydrogen protons, and that is why diffusion weighted images are so important, which pick up infarct as early as half an hour to 45 minutes. So it can be so early. Even by the time patient comes, we put the patient in, we follow the protocol where we do a diffusion sequence first, because we can pick up the infarct so early, and then we can go ahead with other sequences. And I'll show you how ineffective other sequences will be if it is an acute infarct. And this map is called the ADC, or apparent diffusion coefficient map. For easy understanding, this will be the reverse of diffusion. Diffusion, it appears bright. ADCs appear black. Now, acute infarcts are seen only on diffusion weighted sequences. This is a T1 sequence because the CSF is dark. This is a flare sequence because we have suppressed the CSF. But you look at diffusion weighted, there is an infarct in the insular cortex. There is an infarct in the posterior right temporal lobe. There is an infarct in the left frontal lobe. None of these sequences here, T1, T2, or flare, are showing the infarcts. So if you just want to see the infarct, the only investigation is diffusion, diffusion, and diffusion. Now look at this. This patient has a bright area here on flare images, bright area on T2, and even these two periventricular are bright. But when you do a diffusion weighted sequence, the right thalamic lesion is also appearing hyperintense. But when you do the ADC or apparent diffusion coefficient maps, it is not becoming dark. This entity is called T2 shine through. If the infarct is slightly old, because of the increased fluid content, it will not appear dark on ADC maps. So diffusion sequence along with ADC tells us whether the infarct is acute or this is an old infarct and this one is the new infarct. So diffusion is the investigation because ADC comes along with diffusion weighted sequence. Now, the ischemic time course can easily be evaluated on MR. This is a T2 weighted sequence. This is at 24 hours, 7 days, and 30 days. Just look at how the signal changes on ADC maps and diffusion. Diffusion, this is an acute infarct. You're already seeing the infarct. T2 weighted is not showing the infarct. Even at 24 hours, T2 is not showing the infarct. You see the cell size so well, but ADC and diffusion are already showing the infarcts. And along the course of the evolution of the infarct, 7 days, ADC becomes less dark, and at 30 days, ADC becomes bright. That means the infarct is going towards chronicity. Enhancement of the infarct, it is the rule of 3. It starts at 3 days, peaks at 3 weeks, and 3 months it is gone. So these gyral enhancement lesions here, the gyral enhancement is classical for a subacute infarct. If you look at the plain T1, you see effacement of the sulci here, but there is enhancement of the gyri, suggesting it is a subacute infarct. Perfusion. Perfusion is again a very important investigation. It takes 1 minute, not more than 1 minute. We inject contrast at 4 ml per second and we do the perfusion maps. So when we do the perfusion maps, look at this. This is diffusion. It is showing the ischemic core, which is the which is the umbra, and the ADC shows the umbra very well. But look at perfusion. The penumbra is seen extremely well on perfusion maps. So this is the part of the brain which we need to salvage because we cannot do anything for the umbra because this is already gone. It's already dead. But the penumbra we have to save. So that is why it is so important. Please see that the patients get investigated within the first 15-20 minutes. Now, when we do a spectroscopy in these acute infarct cases, you see increase in lactate. Okay, this is superfluous. We don't need this. This is just to show because of the anaerobic metabolism which happens, you see a lactate peak in spectroscopy. Now, pipes. I showed you this in my previous talk. Hyperdense MCA sign, which tells us there is a thrombus within the MCA. Then we go to MR. We do an MR angio. We can see the narrowing of the MCA here. This is another patient where there is occlusion of the basilar artery. So this takes around 1.5 to 2 minutes. Diffusion takes 1 minute. Perfusion takes 1 minute. Rest of the sequence is 6 minutes. So 10 minutes, the stroke protocol is done. Now this is again an angio just to show that there is an occlusion of the MCA here. There is narrowing of the left MCA in this patient. And this case, you see complete occlusion of the internal carotid artery on the right. This is the left ICA, the occlusion of the right ICA. Now, when we do a contrast enhanced MR angiography, we use gadolinium, and this patient has occlusion of the left ICA. So beautifully brought out. You don't see the ICA at all. The right ICA is very well seen. There are two types of angiographies what we do. One is with contrast. Second is what is known as the time of flight angiography. In time of flight angiography, we do not use contrast, but the signal is not so good as that of the contrast enhanced angiography. So I always prefer to do a contrast enhanced angiography because it is more informative. It is faster than time of flight angiography. This angiography with contrast takes 1 minute, but the angiography with time of flight takes almost 7 to 8 minutes. So the contrast enhanced angiography is much better. And post contrast, we can do an axial section, see the thrombus so well within the ICA. So this is a patient again with very tight stenosis of ICA. You can see there is extremely tight, around 90%, and this patient will need an endarterectomy. This is again a contrast enhanced MR angiography. Now, dural sinuses, when we do an MR venography, we look at the superior sagittal sinus, we can look at the transverse sinuses, we look at the sigmoid sinuses here on either side, and we can look at dural sinus thrombosis very well. So this patient does not have superior sagittal sinus, which is thrombosed, right transverse is thrombosed, sigmoid sinus is thrombosed. And these patients, as you all know, can have hemorrhagic or venous infarcts. So this is a venous infarct. And if you look at the anterior portion of the superior sagittal sinus here, it is appearing hyperintense. Always, any sequence, the flowing blood should appear dark. The moment it starts appearing white, you know that there is a thrombus. Okay, flowing blood is always dark on all sequences. One more illustration of a hemorrhagic infarct here. And look at this. These hemorrhagic infarcts are not as dark on ADC as that of the arterial infarcts because the hypoxia is relatively less as compared to the arterial occlusions. Hematoma. The beauty of MR is now you can probably look at the time course of the hematoma, and this is a hyperacute bleed which appears iso-intense on T1 and hyperintense on T2. This is where CT scores. Hyperintense bleed, CT is the investigation of choice. Though we have new sequences, but still CT is the investigation of choice. Now, acute hematomas, they appear iso-intense on T1 and hypo-intense on T2 because of deoxyhemoglobin. So deoxyhemoglobin appears dark or hypo-intense on T2. Then we start looking at extracellular methemoglobin. Now, intracellular methemoglobin appears hyper on T1, hypo on T2. Extracellular methemoglobin appears hyper on T1 and hyper on T2. So you know, yes, this is going towards chronicity. This is late subacute. This is early subacute. So you can age the hematoma on MR, which you cannot do on CT. Now, subarachnoid bleed also, MR can pick up subarachnoid bleed, and these are called as gradient echo sequences. When you have to look at subarachnoid bleed, T1 and T2 may not be of much help. The gradient echo images or susceptibility weighted images are used, or get a CT done, which can beautifully pick up subarachnoid hemorrhage. Now, if you look at tumors, I showed you this arachnoid cyst, which was CSF density. But look at MR, so beautifully seen. You can look at the arachnoid cyst, CSF density on T1, CSF signal on T2, and CSF signal on flare. So arachnoid cyst, have the same signal as CSF on all sequences. When you do a diffusion weighted sequence, there is no restriction of diffusion. ADC is not dark, diffusion is not bright. So you know 100% this is an arachnoid cyst. Now, if you look at epidermoids, epidermoids have signals slightly more than CSF on T1, but they're bright on T2. But the differentiating feature here is they show restricted diffusion. So if a lesion extraaxial shows restricted diffusion, it is an epidermoid. If it does not, then it's an arachnoid cyst. Now let's look at a few tumors. This is very classical. This is meningioma, convexity meningioma, and you see a dural tail, which is almost the hallmark of a meningioma. It's an extraaxial lesion, broad-based. Now, gliomas can be smaller lesions. You can see these are all infiltrative gliomas here, which are not very well defined because of their infiltrative nature. Metastasis, multiple lesions. You can see one in the left occipital, one in the right cerebellar hemisphere. So multiplicity of the lesions tell it is more of metastasis than other lesions. Now, infections. When it comes to infections, you look at tuberculomas, the thick peripheral capsule, and there is restricted diffusion. Whenever there is necrosis or caseation, you know, and if there is a restricted diffusion, it is tuberculoma. If there is no restricted diffusion, I repeat this, if there is a restricted diffusion, it is caseation, it is tuberculoma. If it is not restricting or no restricted diffusion, it is a tumor. Because necrosis in tumors do not show restricted diffusion, but caseation in tuberculomas show restricted diffusion. Now, this is a case of intraventricular cysticercosis, fourth ventricular cysticercal cyst. In fact, this black dot is the scolex. You can see the scolex also here, and you can see the cyst wall surrounding the scolex, which is obstructing the fourth ventricle, giving rise to obstructive hydrocephalus. So this is an intraventricular cysticercosis causing obstructive hydrocephalus. Cysticercosis are smaller lesions. You can see this, smaller lesions, and they can be conglomerate. You can go back and see the Escobar classification for cysticercosis. So these are degenerating cysticercal larvae with surrounding edema. Conglomerate tuberculomas, multiple tuberculomas here with T2 hypointensity, which is again the hallmark. And when you do a spectroscopy, you see a very large lipid peak because of caseation. So tuberculomas show restricted diffusion, and they also show increase in the lipid peak. Meningoencephalitis, you see the cortical involvement here. This is a T2 weighted sequence. This is a flare sequence. Patient with clinical suspicion of encephalitis. So this patient had encephalitis. You can see expansion of the gyri, hyperintensity, but there was no bleed in this patient. Multiple sclerosis, again, demyelinating lesions. Now, classical demyelinating lesions, you see now periaqueductal is one area, and perpendicular to the ventricular walls, what we call as the Dawson fingers. They are perpendicular to the ventricle, and acute plaques enhance on gadolinium. So all multiple sclerotic cases, we have to give gadolinium. And you can look at this plaque, which is showing tumefactive necrosis. You see a central hypointensity with surrounding hyperintensity, which is the enhancement. So multiple sclerosis, it's important for us not only to look at the brain, but we also need to look at the optic nerve. You can look at the optic nerve here, which is bright on stir sequences. We have suppressed the fat. The nerve is standing out. And then we can also go ahead and evaluate the spine for multiple plaques plus optic neuritis, which is DEVIX, which is neuromyelitis optica. This is a case of extensive demyelination. You can see the periphery, which is enhancing so well with central hypointensity. So what I'll probably do is the last 5 seconds. This is hippocampal sclerosis. You see atrophy of the hippocampus, and you can see the atrophy of the hippocampus here, and we can also do a spectroscopy which shows decrease in NAA levels, N-acetyl aspartate levels. So this is atrophy of hippocampus with decrease in NAA levels, plus the T2 value will be more than 105 milliseconds. You can calculate the T2 values also. So with this, I think let me conclude and open it up for any questions. And one last thing here, one last, which is very critical at this juncture is, this is an intracerebral hematoma, acute subdural hematoma, acute infarct, dural sinus thrombosis. Now, you know the diagnosis. What is the cause? Anyone? What could be the cause? Please don't forget COVID.